Hey everyone. Wanted to say first, thank you so much for inviting me back this year. I think that this is probably my favorite place to go among all the conferences I go each year, mostly because of who I'm speaking to. And it's that I think the audience that you guys collect here are the people who represent all the groups that will benefit the most if we make this happen. So you're the most important people to hear kind of this message about value-based healthcare, but also the most important one to take that message and drive it home to both our policymakers, our clinicians, really everyone involved in the healthcare industry. So I think that Louise told me this morning you'd hear kind of from Scott on what is value-based healthcare and a little more of the examples and things from around the world that big places like his group over in Texas have worked with and the Harvard group have worked with and kind of categorized. And then you heard from Fred a fair bit about what's happening in Canada, and a fair bit is happening here excitingly, and I think that there's a lot of potential for Canada to do much more in this space as more things organize around groups like the one Fred and the team put together for the value-based healthcare group in Canada. But what I often get asked by individual patients is that they say, well, I can see that there's these things that everyone puts on the board, which is that the payers will be more efficient, which means they have to be able to kind of deploy their resources more effectively. Clinicians will know kind of what outcomes to achieve and how to treat different conditions better. But really speaking, other than kind of large system change, what specifically gets impacted for patients if we start to measure outcomes? And so that's what I want to talk about today. I'll try and be brief, and I limited my slides to just 5 slides for an ex-consultant that is impressive. And so I really have to hold myself back and putting less on there. But I want to say, what do you get if you do this? And not what do you get long-term, which is, a better and probably more stably funded healthcare system with smarter outcomes for clinicians and really something to point to. But what do you get in the first 5 to 10 years, let's say, or first 5 years, if we start to measure outcomes as patients? Oh. So not all of my graphics are showing up. Oh, they are there, interestingly. But long story short. No. Did my best. They show up there, so I can see them, which, is nice. But I think that there could be a whole slide of about 50 ideas that happy to discuss with anybody on what you specifically get. But want to pick the 3 that I thought were most compelling and that there's reasonably good cases for. And the first case, or the first thing I think that you get by adopting value-based healthcare as a patient group or as a group of patients is that it helps you know where the teams that are doing the best care are and who you should choose for your care. And that's currently something that's absent in almost every market in the world, other than some unique cases in, let's say, the Netherlands and some parts of the UK and a few other places. But really speaking, knowing who treats your disease the best is the best at a certain procedure and is the best at your patient type is completely absent. So let's talk about how you would know that and how, for given hospitals, them knowing what they're good at allows them to improve quite drastically. And I'll talk about a case that I'm not sure if Scott touched on, Martini Clinic. A little bit? Okay. I'll talk on it tangentially then and not go too deep there. But that's probably one of the best examples of that as a topic. The next is that if you're measuring outcomes, one of the things we don't really have in healthcare right now is what everyone's been aspiring to the last 10 years, which is what they call shared decision making, which is all like a big pillar of patient-centered care. They say we should make all decisions that are with an informed patient and share that decision-making power. But if you don't really know what you get that's different, if you choose drug A versus drug B, or procedure A versus procedure B, and usually it's not that simple, it's usually care plan A or care plan B, then you really don't have much of an ability to say, well, that's the way I want to go. I'd prefer not to have that surgery this year because I'm not that symptomatic. I know that the downside risk of surgery is this, and I think that given my current functional status, I'm okay. So even if there is, let's say, a blockage in this artery, I'm good. I can step back. I can wait for a while. Or on the flip side, I at least know that the next 6 months is going to be terrible after this procedure, but for most patients like me, it tends to improve after that, so I'm willing to go into that eyes open. So knowing what's coming is kind of the second promise of what you get if you measure outcomes properly. And so I want to talk a little bit about that, and we'll talk about what's it called, Partners Group, and specifically Mass General Hospital in Boston is doing there. And I'll give you a website to go look at, and we'll cover this more tomorrow in my talk on kind of what it is you have to measure to make this happen. And then finally, actually improving the care process and the communications between patients and doctors. When we talk about value-based healthcare, we often talk about measuring outcomes so that you can correlate them with costs and then have an overall improved system. But actually, the act of measuring those outcomes is the most powerful thing that one can use in a clinical interaction process. And what they've done at Mayo is really they said, your system-level value-based healthcare stuff sounds really cool, and you'll change the world. What we think that this outcome stuff is really relevant for is that suddenly now we have a very objective way of hearing from each patient what specifically is going right and wrong for them from a symptom and functional status perspective. And having that on its own is magical because now we can center our conversations. And this particular group is a psychiatric group that works with cancer patients at Mayo. And they said, usually you walk into an office and you say, kind of what's going on? How are you doing? What's your biggest complaint? Now they walk in and say, well, we see that you've had trouble sleeping. We see that you have had these sorts of feelings of depression and anxiety over the last few days. And we see that from a functional status, this is where you're at. Let's center our conversation here. And so let's talk about how they've used that to kind of improve care. So the first group, and I won't tell you the background because it sounds like you know, and you're all experts about Martini Clinic, but it's a really fascinating place started by a fascinating guy named Herbert Hovland over in Germany. And what they basically said is that we are going to be intensely focused on how the different things we do in the procedures we perform impact outcomes. So we're going to study that and we're going to make it an art form. And they really spent a lot of time trying to think about, okay, each time we make a change, what is the impact? Are outcomes better or worse? The result was that they were able to get far better outcomes than really anybody else in the country and the world when it comes to prostate cancer surgery and radical prostatectomies particularly. Now, that on its own sounds interesting. Okay, so they can improve their outcomes by using it, but what does that mean for patients? So when you look at somewhere like the Martini Clinic, where they measure the same set of outcomes that other people do, and those are at an individual patient level. So for example, things like erectile dysfunction after a prostate cancer, radical prostatectomy, or incontinence, or pain, or physical functioning overall. When you're measuring these things, you can actually stack them up against each other. And that's literally what you can do with the Martini Clinic. And so, don't know if Scott showed this, but if you look here, kind of just two key graphs, or two key stats from Martini Clinic versus others, when you look at their incidence rates of both erectile dysfunction and incontinence. And you can see that if you are an individual kind of deciding that, or you've been diagnosed with prostate cancer, and you've been told that radical prostatectomy is the right way to go, and that's the primary option you're going to take to treat this, it would be really good to know, sitting somewhere in Germany, that if I go to the Martini Clinic, about a 37 to 40% chance that I'll walk away from the situation with erectile dysfunction. Everywhere else, it's double that. Looking at incontinence, kind of a 6x difference. So suddenly it allows some choice. You're like, what is it I want after this surgery? It seems like everybody's good at mortality, and this is the case in Germany. I think it's some 96% is kind of like the average survival rate for 5 years after the surgery. And so that's not really going to be the differentiator. But if you look at these individual outcomes, suddenly you get to choose. You're like, well, that's the place I'd really want to go, because those two things matter most to me. And for men who are going through prostate cancer surgery, those two things tend to be ones that matter a lot. So that's the first thing this kind of system paradigm change brings you. It brings you an understanding of what you can expect from a given procedure and where to go to get the best care possible for you, given the outcomes you want to achieve. So that's step one. Let's talk about the next one, which is Partners Healthcare. And I'll give you a website. Maybe we'll send it out with the group. It's, you can Google the words care decisions and partners. And their website, I think it's caredecisions.com, will come up. But what they've said is that, the primary way we want to use this data is that, again, in the future, we want to be able to take this outcomes data, benchmark it against our cost data, benchmark it against our different procedure data, and learn a lot about how to improve outcomes, as well as how to manage costs and deploy things more effectively once we know that equation of value. But in the short term, what we actually find this most useful with is that we always have an incredibly difficult time describing to people what they should expect when they have a different procedure or surgery option in front of them, and what to do, how to make that choice. You can say that most people do better. What is better? And better on what kind of metrics? And so what they've done is they actually go, and if you go to Care Decisions, you can see, I think, the last 700 surgeries in both heart disease, hip and knee osteoarthritis, spine, and there's one other there. But what they actually do is they post it online. They say, okay, from a functional status, from a pain status, from a overall physical functioning status, this is how the average patient of ours has performed. And they have a kind of a very interesting goal, which is they want to be able to segment patient types quite a bit more detailedly than that. But as one hospital, they only have so many surgeries a year. But what that has given, and what they've published on pretty extensively, this is the the op-ed there is from the New England Journal of Medicine, is that if you actually are able to sit down with a patient and say, okay, if you're going to have a total knee replacement, this is how you can expect your pain to look like starting now from where you are today to 1 year after the surgery. And let's graph that out. And this is kind of pain improvement, so lower pain is higher is better in this case. And they say for the average patient, this is what you'll get. And so when you're making that decision on whether the surgery is too risky or not risky, whether you want to do this, in the US there's a financial constraint as well. And so when you're making that decision, this is what you can think of from the pain. They have a similar graph up there from physical functioning, similar graph up there for, I think, level or ability to actually do activities, and they have a kind of a range of activities. But suddenly you have a sense, you can anchor this into, rather than, well, if I get a better hip, I'll be better, or I get a better knee, I'll be better, you can start to say, okay, what specifically is going to be better, and is this worth it for me? And that knowing what's coming, for them at least, and for their patients, and they've published this again, and really codified it, they find that it makes both people much happier because everyone goes into it knowing what to expect. And that's partially what's missing it often, is that people really don't know. They're like, I got told to do the surgery, so I did the surgery. Not sure if it was good or bad. I think it was probably good. Someone smart and someone I trust told me, but that's it. And now it's one step, no, I think I did the surgery, I knew what was gonna happen, and most things turned out in that way, is a much more satisfying experience. Last example for today. So now you've been able to pick the right kind of clinical team to kind of treat your condition. You know what's coming. How should these outcomes be used in your interaction with your physician? I think a lot of people look at outcomes in the traditional value-based healthcare sense, especially from the health economist side or the policy side. They'll step back and say, these are primarily measurement tools. We want to use these outcomes to measure how we're doing. And measurement is great, but actually what they are clinical tools. And if you just create a bunch of measurement tools and they have no clinical applicability, chances of doctors and patients taking the time to actually report on them is very limited. Because even if it's 10 extra minutes per day, I think all of us know that if we did 10 extra minutes of any one activity, for me it's going to the gym per day, I'd be in vastly better healthcare status, but I'm not going to. Or I don't do it that often. I'm going to try to, I should say. But if I have to think about that in the context of I might improve an overall health system over the next 5 years for all the people in a country, chances of doing that quite limited. If I know that if I'm going to respond to a series of questions about my physical, functional, and kind of symptom status, and that is going to be used in my next clinical visit, suddenly that changes the level of utility for me. And that's why outcomes have to be kind of live and used. And the way Mayo is using it is that the cancer unit there is focusing on patients with depression and anxiety. And what they're trying to say is that if we get them to answer all these surveys, it's not really just so that in 2 years we can look back and say, okay, this procedure and this treatment pathway resulted in the best outcomes. It's no. We can use these right now in each clinical visit to actually communicate with a patient. And what they do is that in the waiting room, you sit down, you answer the PHQ-9, which is kind of a depression and anxiety survey, and a few others that are listed for them. And then based on those responses, a bunch of flags pop up for the doctors. And so in the back end, the doctors get a screen that looks like this. Actually, a Toronto-based company called Input Health helped them design this and actually worked around Epics to actually do this kind of functionality for them. But they go ahead, it pops up on the screen, they say, okay, well, this person's worried about these 5 things, or these 5 things have changed since their last visit. And so based on that, they suddenly can walk into a clinic visit and fundamentally kind of realign on what exactly has changed and what is wrong since the last time you came in, rather than this kind of big open-ended question, kind of like, have you had any events since the last time I met you? Anything new bothering you? No, now it's kind of structured and codified. The reason the physicians love this is what they've done. They said, okay, well, if I'm going to make a patient answer 30 questions, I know that what the impact of those questions are from a clinical sense. To similarly getting a lab value, now I'm getting a subjective measure of a patient's functional status and symptoms. So they've actually coded that into a form which pre-populates their clinical note. And so in the US, this is one difference from Canada, I think still, I don't know. I haven't had enough interaction with the Canadian healthcare system recently. But if you walk into a clinician's office, generally speaking, half of your visit, they have to be typing. And for every 15 minutes they see you, they spend 45 minutes kind of in the back room typing up the clinical note. And that's for a lot of legal and billing issues, which are terrible and have to be solved there. But long story short, that piece is the bane of every clinician's existence. By getting a patient to answer this, not only can they focus the visit, but they save about 15 to 20 minutes on the note because it just pre-populates for them because they know what they're asking. They don't have to write it. It's structured. It's a structured response. And so both sides win, and these guys are really, really, really enjoying this. They're going to publish some of the outcomes on the actual endpoints in the next couple years, because they've been measuring that for a little while, but the initial data, I believe, looks very promising there. So that was kind of like drinking by the fire hose. I know that was short and I think 12 minutes or so, but what I want to say is that this kind of whole value-based healthcare thing, it's not just this big system-level way of improving healthcare for everyone at some point in the future if we can do better measurements and costs. It impacts the way you will interact with the health system tomorrow if you get it right. And these are kind of very specific, and there's more, but very specific ways that for each individual patient, it would change your interaction with the clinician and yourself. And so hopefully that gets you a little more excited to do this, because it's not some kind of like nebulous policy decision of how do I save the government of Canada money so we can spend more education, though that should motivate you. But really today, it'll improve your healthcare if we do this. And that's where I want to end. Thank you.
Any questions for Fred or Andre? Yep, there's one on this side of the room, another one up here in the front, and one in the back. Yeah, we can start with you. You've got the mic first.
Okay. Thank you very much, gentlemen. I appreciated the presentation. I have a quick question with regards to this value-based healthcare. It does sound like it's contingent upon open communication between doctor and patient. And my other point is, for the patient to have significant input, I think the patient needs to know the knowledge of the right questions to ask. So for instance, I mean, I've consulted with a lot of patients, and you know what they ask me, well, I want to know, am I getting the right care? And you know, there's a great book called 5 Questions to Ask Your Doctor by an oncologist at London Health Science. And you know, I mean, a lot of patients don't even know what you're referring to when you mention, does your hospital have a tumor board? And you know, when it comes to guidelines, patients never heard anything like the NCCN clinical guidelines for treating oncology. And you know, once they've been informed of that, they're very, very much attuned as to what they want to ask the physician. But I guess my pet peeve is patients don't know what they don't know. So I think it's imperative in this type of thing, from my perception, that it be an informed patient participating in the process. And if the clinician has the time and the inclination to participate in the process. I just wondered what your comments were, if that's naivety or if that's correct. Thank you.
Here we are. So I don't think it's naivety. It's definitely correct, but I think that if you want a patient to know everything about a condition, from which tumor board is going to look at, or how a tumor board is going to assess their given tumor type, or how their care pathway is chosen, or like the last 3 most recent studies on kind of drug types, and what are the new emerging clinical trials for their condition, then they're kind of becoming doctors. And that's a little difficult. And that's a big ask in addition to everything they're dealing with in their condition. So I think what you'd want as an informed patient is, you don't need to know all the science behind how cancer is discovered, treated, managed. What you need to know is, what would you expect from your different procedures in front of you, and how would they differ from one another? And then how would different clinicians differ from one another if they were going to treat you? And that's that basal information, which is that if I have this, at the most basic level, and this, at least, information is out there, it's not well tabulated, but which place am I going to survive, or has the highest chance of survival? That's your most basic outcome. Then one step further, what is my physical functioning and symptoms going to be like over the next 5 years if I go with this procedure type or this clinic? And so if we can all measure the same things at the outcomes level, which is really first kind of the bigger ones like survival and that kind of stuff, but then more specifically on the ones that matter to us in daily life, like symptoms and functional status. Will I be able to walk? How much is my pain going to be? How much fatigue will I have? Then you can compare between places on that. And that's the level of information, I think, that should be available to patients at every place. And that should be what gets you informed. Because now you know your options, and then what is the difference in the impact on you by those options. Whether or not you know if the tumor board kind of comes together or not, probably you don't care as long as they do it right. What you actually care about is, what am I getting different here at your hospital versus another hospital, and with this procedure versus the other procedures you have offered to me. And that, I hope, is the kind of basal information that everyone can get and will make patients informed in these decisions.
Thank you. Another question over here on this side of the room, and one up here at the front.
Thank you for the presentation. It's really good to know that there are other examples, not just in Canada, but around the world as well. My question is, the delivery healthcare system in Canada oftentimes is delivered provincially, sometimes at the health authority levels too. Earlier today, and even with Scott Wallace, we talked about delivering or evaluating healthcare system examples at the local level, that we should start at the local level and work our way up. Do you see that as a barrier in terms of how we deliver healthcare system? Because it is addressed sometimes at the local level too, and if you go across provinces, sometimes we don't get the same type of care, same type of coverage, and a lot of times that creates a lot of barriers to patient access.
Yeah.
Thank you.
Thanks for the question. I don't know that I'd characterize it as a barrier. It's certainly a challenge, and we've spent billions of dollars in Canada on trying to replicate things that have proven to work well and have them offered consistently across the country. What I think is different about value-based healthcare is that it's actually grounded in the outcomes to begin with. So if a group of patients in a particular area, a particular disease or condition, agree, it's not about clinical efficacy. So in Canada, as Andre was just saying, I mean, the intricacies of a given procedure, you want to understand those, obviously, as a patient. You want your family to understand them. But your interest doesn't start and stop as to whether the operation was clinically effective. Things that are clinically effective, they're not necessarily all going to be connected with the same outcome. It could very well have to do with the primary care that you received after the surgery, maybe the support you received as a patient or from a patient organization. So I think the way to overcome the challenge you're talking about this 13 health systems, and you trying to work with them as patient groups, is to really start with articulating the outcomes. And your tax dollars are actually being invested in developing patient-reported outcome measures. So if you look at organizations like HiHi or CADIF, I mean, there's people out there that are being funded to do this sort of thing. So you can leverage that in terms of guiding them in the discussion to map the outcomes that, as you'll see in all of this, it's about the outcomes that matter most to patients. Once you've got those, then I think for your particular interest, whatever it might be, in the health system, you've then set a level. You've got a level set. And as patients, you have the opportunity to influence everybody else to work from your level set of outcomes. So I think that's really what we need. It's probably going to start locally. You can't boil the ocean, obviously. But that's how you get a discussion that stays in the same framework as you move ahead.
Okay, thank you.
Thank you. Thank you both. My name's Tom Conway. I'm with BC Schizophrenia Society. And what, Andre, the presentation you just gave seemed to me that there was a lot of clinician and patient collaboration in each of those, and highly successful organizations in putting those outcomes and value together. And we talked earlier about starting at the local grassroots kind of patient group level, but I also have limited resources and competing priorities in how I put that together. And what you said earlier, Fred, about getting clinicians to support this kind of activity is challenging. And so I don't want to devote a lot of resources to something that that is not going to go anywhere if clinicians aren't going to use it, or if somebody. So you may have addressed that in what you said earlier about CADIF and CIHI having funding available. Are there funding sources that can help support us in doing that?
Well, I mean, I can't speak for individual organizations. I think there's a lot of interest in investing in this, and certainly industry. You saw some of the logos on the projects that I talked about. So there's certainly industry is investing in it. I think the Pan-Canadian health organizations as well. It's about how do you do more with the same, not more of the same. If I was in your position, I'd want that same as much assurance as I could get that the investment of effort was going to lead to something. I think and I hate to say it because it's sort of become cliche, but where's the coalition of the willing around this? Well, it's really growing in Canada. You've got 2 assistant deputy ministers in the room today from 2 different provincial governments. You've got patient organizations, you've got industry, you've got dinosaur politicians, you've got leading researchers. But, you know, so it's there. I think it's a case of coordinating what we've already got. So it's different than a traditional advocacy approach, right? It's different than saying, you know, you who's going to be minister for maybe a year and a half in province X, we really want you to focus all of your time on value-based healthcare. That's not going to get you the change. It's actually articulating what the outcomes are. It would be very interesting to see a project, and I shouldn't think out loud, but it'd be very interesting to see a project organized just around patient-identified outcomes for, say, 2 or 3 key areas, and not to suggest that one area is more important than another, but if you think of chronic, what are all of the outcomes that are common to patients living with chronic disease in Canada? We know about 5% of Canadians use about 60 to 65% of healthcare resources. A lot of those people are with multiple morbidity, multiple chronic diseases, who are, you know, unattached to the health system, or they're not getting what they need, or they're not able to go back to work because they're not getting a functional outcome from their interaction with the health system that they need. Probably may have something to do with the drugs they have access to. It might have something to do with which doctor they're seeing. But likely, I think it's because the discussion or the interaction between the patient and the health system isn't framed the way that Andre just described. Like that's a big part of the value. Not sure I'm helping, but some thoughts.
I'll add exactly 2 seconds to that, which is that don't know anything about funding sources. So that, I think, is more on the what Fred knows far more than me. But there's kind of this belief that often comes up, which is that the hard part of this is convincing doctors to do it. I think the hard part is making them aware. Convincing, actually speaking, doctors, one thing they hate more than anything else is another kind of management professional or government group kind of telling them, here's a new way to do your job better. Because frankly, that's happened about 10 times in the last 10 years with different Lean Six Sigma models or whatever else you want to talk about. And almost all of them have made patient and doctor interactions worse. The people that they really want to help and hear, hey, this is how you could improve my care from, is from patients. And so I think that you're in a very unique position to talk to and recruit doctors who are your caregivers in a field of specialty to this cause, because they are very excited to say things, well, if this would actually help you, yeah, I'm up for it. But if someone from a government group says, well, we think this is how you can help your patients, they're like, really? When was the last time you talked to one? And the answer is usually not that often. And so I would say that maybe on the mindset that doctors will be impossible to bring along and that they're the hard part, it's not that they're impossible to bring along, it's that they have to hear the message from the patient side as much as they hear it from the other side, because the other side has told them a lot of things which have not improved patient care over the last 15, 20 years.
Okay, thank you. I have time for one more question.
Thank you. Just following up on the first question and the second speaker, selecting the best care team. First of all, there's asynchronous information between provider and patient. So as a patient, you don't know what is necessarily the best thing to do, number one. And depending on where you are, you might get different advice. So getting a second opinion is a good idea, perhaps. But if you're trying to select the best care team, I know here in Toronto or the GTA, a lot of times people are going to, for cancer, downtown, Mount Sinai, Princess Margaret, Sunnybrook. And these hospitals or these care centers they have a great reputation, and they get flooded with people from outside their service area, simply because of the reputation. So when you say that if you're in Germany and you are diagnosed with prostate cancer, if you know the stats about the Martini Clinic, you'll go there. Well, if every German man knew about that, then the Martini Clinic would not be able to cope with the volume, right? So how do we spread that information, that first of all, that patients know where to go, number one, that they understand there are choices in treatments, and that the local place that they're at may not have the approach that is most appropriate for them. because selecting the best care team sounds like a great, great philosophy. And as a patient, I was lucky to have been able to do, I was happy with what I did, but it was only through sheer luck, really. It wasn't by design. So how can we make it by design that patients can actually get that best care team?
So I think there was actually, I'm categorizing all the different questions there, but I'll try and check them off one at a time. I think that the first thing that I would say is the difference between reputation and actual quality is not insignificant. So there's a lot of very highly reputable places, and I've looked more at the US than I have Canada, that are very good at a few things, but not fantastic at other things. So going on reputation alone probably isn't the way to go. The way you get this information to patients is that if all hospitals in a given region, Ontario or Canada, are measuring the same set of things in terms of patient progress after a certain procedure type or for a given condition on a yearly basis, then suddenly you have the same apples to compare across all the different places. Much in the same way that mortality and sepsis rates are measured everywhere, if you have the same outcomes on after hip or knee surgery, that's an easy one because everyone kind of can visually understand that, after his hip and knee surgery, an individual's ability to walk, jog, run, do exercise, as well as their pain, as well as their ability to go back to work, as well as their fatigue levels, then suddenly you can compare that between hospitals and know just based on that which one is likely the best. Now, the second question, which is that as soon as you have that, you'll find some hospitals are fantastic and some are less good, and there's different reasons for that. The less good ones can start to learn, and actually I'll put this on a slide tomorrow for you, and as a quick aside, because there's a Swedish example of this where they did just that, and they said, well, what's going to happen is that basically everyone is going to start looking at the one hospital that's great, and no one's going to go to the other ones. Actually, in Sweden, what happens, patients didn't actually notice or take notice because they weren't really the ones reading all the data reports, but the doctors hated the fact that their hospital was at the bottom, and so they all accelerated up, and they got really tight as a group. So there's that one like outside effect that just publishing this information, doctors are super competitive. They love to actually compete against one another, and everyone kind of improves. But on that other side, which is that, will volume overwhelm the best places? Yes, but. So Martini Clinic, yeah, volume could overload them, but they keep adding, like I think they are now the largest prostate cancer surgical unit in Germany by far. They have 12 or 15 surgeons. That's a few years old, so it might be much more by now. And they keep adding. They do something like 6 or 7x more procedures than anyone else in the country, and they keep growing. And it's because they have a steady demand, and that even things like travel don't stop people from going there, because they're like, look at the difference in outcomes. And Germany, it's a government-funded healthcare system in large ways, and so they are able to kind of go there and get their healthcare done. And it works, and so if in the world you find out that there's a place that, really speaking, I could get vastly better outcomes and be able to live a more fuller life afterwards at this one center, it's not bad for that center to necessarily grow. But I wouldn't say that you're going to have a world where all community hospitals are going to shut down and there's going to be like 4 in Toronto that take care of all procedures. Generally speaking, kind of the tide will lift all boats, but those big ones will grow and they will be the ones that innovate on what are the best new procedures going on. And chances are for some certain, especially the rarer conditions, you're going to want to travel with them.
If I could just add quickly to that, because it is different in Canada, and I take your point about, our ability to exercise choice is somewhat limited. It's limited by knowledge. It's limited by the nature of our system. And, quite honestly, a lot of times people are just grateful to get in as opposed to having a chance to make an informed choice. There's ways in Canada that are already happening that will allow the system to respond to the ability of a provider to achieve these outcomes. So in Alberta, for example, there are now 16 hospitals on activity-based funding, which means rather than a global budget, a hospital is approved to perform a certain volume of procedures. I'll use hip and knee just because it's a simple example. So they're funded to perform a specific volume of procedures in a year based on their performance. So for some areas, even though we're a single payer model, we can organize our funding differently so that there is some internal competition and you can exercise more informed choice. Ideally, what you'd want to see over time is, when you first set the outcomes, more variation, greater discrepancies in outcome at different locations. And over time, if the system's really working, those variances would get narrower and narrower so that you had a more equitable achievement of the outcomes across the board. So again, like I said with fee-for-service funding, you know, it's really important not to, because we're Canada and because we're organized the way we are, it's really important not to get discouraged by some of these structural things. I think as what we're trying to say is if you take the role, and you don't need permission to do it, to articulate what the outcome should be for patients with, in your particular situation, disease or condition or what have you, then you know the system will be forced to respond to that. Nobody else is doing it. People are doing little bits and pieces of it in pockets, but that level setting is what really needs to happen.
I think, thank you. I think what you're saying too is, you know, standardization is where you're going with this, right? But one of the things, and I'll just make one last comment, is that, and I don't know if this exists in Ontario, but the clinical practice guidelines for a specific disease, for instance, you know, is that rolled out to every single care center at the same time, et cetera, you know, or why does it take, you know, significantly longer in some places to have that change in guidelines reflected in clinical practice. So, but I'll leave that. I know we're running out of time, but that is something that I would like to see addressed. Thank you so much.
Thanks,
If I could
everyone.
respond to that for 30.
Okay, we're 10 minutes into someone else's time, so I just
Apologies.
want to...
For the clinical practice guidelines
space.
question, definitely agree they should all be rolled out everywhere because they're usually baseline evidence for things. There's something to be said, though, that the reason sometimes doctors don't follow guidelines is, one, they don't know. In this case, they should. But more often than not, they sometimes would disagree given the situation of the patient. And in that case, if it's their prerogative to disagree, if they disagree, if they're producing better outcomes through that disagreement, then they kind of create the new guideline as time goes on. And so the word standardization scares me a bit if we standardize how patients are treated. If we standardize what we measure as the outcomes of what comes from that treatment, that is fantastic. If we standardize how patients are treated, we stop learning how to treat people in new and better ways. And so that should be kind of a salient differentiator.